Susan Davis asked me to basically cover the waterfront, so everything, you know. So Dave has given you a beautiful overview, so I will be fairly brief in my introduction. So no real disclosures. Life expectancy is now in the developed world pushing 80 years, right? So we have huge population of women worldwide who really need some sort of therapy, some sort of care. And the focus, again, you've been hearing a lot about World Menopause Day. Our focus in 14 was prevention. And it's what Amos said, it's not just hormone replacement. You know, when women enter menopause, for the next 10 years, they develop all the risks associated with longevity and quality of life. All the diseases increase after that. So we're all about prevention, and that includes lifestyle adjustments, including control of body weight and so forth. And here, the consideration of MHT, consideration of hormonal therapy should be part of that equation. Because, as David alluded to, and this is a recent summation of the data, if you look at all-cause mortality, when estrogen is given to younger women, it's at least a 30% reduction in all-cause mortality. That's thousands and hundreds of millions of lives worldwide that could be saved by a preventative therapy of hormone therapy. Although that's, you know, a little bit of a departure from our normal recommendations, because in green, symptoms, as David told you, is our primary mode or reason or rationale, vasomotor and vaginal atrophy. You heard about osteoporosis. That remains an important indication. And I raise the question, prevention of coronary disease and all-cause mortality is emerging or re-emerging. Menopausal symptoms are not just hot flushes, as pointed out here. Genitourinary problems, sleep, anxiety, arthralgias. So in Asian women, bone aches and pains and arthralgias are probably more dominant and more important than hot flushes. All of these relating importantly to the quality of life. This is an analysis by Sally Salpeter, so it is cost effective, right? So if you think, and it's in the same amounts of money of quality adjusted years as treatment of hypertension, for example. So if it's cost effective to be preventing high blood pressure, estrogen therapy in younger women in the upper panel, I don't know that I really have a pointer here, in the upper panel shows significant cost benefits. In the lower panel in older women, it is really less effective, and that is because of potential early harm. I put together a model here telling us where we are. If we start, I wish I had a pointer, if we start right at the top, because of observational data and a lot of experience, HT, or hormone replacement therapy, was used for symptoms and prevention. Then, if you go to the left here, because of the HERS trial, WHI, a number of randomized trials, we went all the way down, and in 2003, after the first publication of WHI, no hormones were used by anybody, for any reason. We're now creeping back on the right ascent part of the model, with some updates from the WHI. Okay, it may be okay for symptoms. Then we had further updates, meta-analyses, the timing hypothesis, all the way back. And so now in the middle, HRT for younger women, we can consider it back to where we were, coming full circle, that it may have an indication for prevention. Now to the nitty-gritty, the sort of the nuts and bolts, okay? So estrogen is the most effective therapy for symptoms of menopause, and this is just one of many meta-analyses showing this. There's a dose-response relationship compared to placebo. There's a substantial placebo effect, so you need to compare efficacy against placebo, but it's very much dose-related, and it takes anywhere from 6 to 8 weeks to have true efficacy. A little bit of pharmacokinetics. Oral estrogen goes through rapid hepatic conjugation and degradation, and so the splanchnic extraction, if you will, results in higher levels of estrone in the circulation than estradiol, right? So the predominant estrogen in the circulation, if you can look at the scale here, this is estrase or micronized estradiol, it's the same as estradiol valerate, is much less estradiol than it is estrone. And if you look at two preparations here on the bottom are estradiol levels, or in picomoles, relatively low levels, whether you're giving estrone or estradiol valerate by mouth. The highest concentrations are of estrone, and this is primarily because of this rapid splanchnic extraction and the conjugates estrone glucuronide being the predominant one. So estrone glucuronide and then ultimately the sulfate, which is a large pool, reflects this oral first passage effect. Affected by certain lifestyle adjustments, this was alluded to by David. The biggest one, I guess, is alcohol for increasing levels, and smoking, reducing levels. But there are many other metabolic fates as well. Transdermal, what about going non-oral? Again, another meta-analysis. A nice dose-response relationship exists if you look at the sort of the greenish-blue bar going down, very much dose-related compared to placebo. The higher the dose, the greater the efficacy. In terms of equivalency, this has been always controversial and difficult to determine differences in potency between oral and transdermal and between transdermal. So this slide points to the rough equivalency of a 1 milligram gel transdermally versus the 50 microgram patch. But I want to point out in the box is that even though these are considered equivalent, the kinetics are relatively steady state. So compared to oral, where you get a lot of sawtooth metabolism, you have a fairly good constant steady state, not quite zero order kinetics, but fairly constant levels with the transdermal route of administration. But note, the bottom panel, the inter-subject variability is real and a great component or a great standard of transdermal therapy. So if you look at these equivalent doses of 1 milligram and 50 micrograms, it gives you about 200 picomoles or 60 picograms of estradiol. And if you're giving it the patch by estradiol, estradiol is what you get in the circulation, not estrone. Estrone levels are lower. But it goes anywhere from 200 to sub 100. I mean, so there could be a 50 to 100% variability in levels in a woman between the same product. And whereas that woman will maintain that level, it could be half of what it is for another woman. So it needs to be adjusted accordingly, and that is because of cutaneous metabolism. Now, in terms of oral to transdermal, how do they equate? And this is complicated, particularly if you use conjugated equine estrogens, because the equine estrogens are not easily measured and they have a different metabolism. This is a recent study from the KEEPS trial, which is now in press, and it shows absolute equivalency and sustained reduction of hot flushes. Okay, so most hot flush studies have only been 3 months. This is 4 years of data showing that dose equivalency suppression of hot flushes is maintained throughout. And the doses here are 0.45 of conjugate equine estrogens and the 50 microgram patch. And I could make the argument from blood levels, extrapolating that those are the equivalent doses. But here, the proof of the pudding is that in terms of symptom control, they're absolutely superimposable, out to 48 months. Oops, am I stuck here? Go to the next slide. Okay. Vaginal health. So there is a little controversy. I mean, truly there's efficacy. There's no question. I mean, you deliver estrogen to the vulvovaginal area, you'll have improvement. But there has been controversy about levels achieved if you give it to a truly atrophic vagina or that one that is already estrogenized. So on the top panel, you'll see this sort of burst effect, a higher systemic level if you give it at initiation to an atrophic vagina. But not all data show this. If you look at the bottom panel, data from Dixantin shows that compared to the pretreatment, the levels up to 12 weeks were not really that different. In fact, levels at 12 weeks were even higher. So it's not entirely clear, but with low doses of, and this is micronized estradiol, this is the Vagifem product that releases 10 micrograms or 25 micrograms. they're basically below the postmenopausal threshold of about 20 picograms per ml, by and large, and obviously a dose response. If you use a large volume by tablet or by cream or by gel to the vagina, you'll get systemic levels, and that's obviously something you don't normally want to achieve. So the 1025 microgram keeps you levels, whether you initiated initially in an atrophic vagina or not. This is chronic treatment, more so with chronic treatment. They're all sub 20 picograms per ml. However, even though the systemic levels are so low, and you're getting efficacy at the level of the vagina, there are data, mysterious if you will, that you with those low doses will get an improvement in vasomotor symptoms, in bone density, in LDL cholesterol. And recent data have suggested that you can reduce cardiovascular mortality as well. And the top panel, these data from Tommy Nicola, the top panel, CHD, the bottom panel, stroke, by years of use. So 5 years, you reduce all-cause mortality by a substantial amount due to cardiovascular benefit. Now, I have to think that this may be a healthy user effect. I cannot believe that 10, 15 picograms of estradiol is gonna make a major impact, okay? But it's all good. All right, so what is the characteristic difference between patch and oral, as shown in this little cartoon here, okay? So, if you give it bypassing the liver, all right, you avoid some of the increase you get in terms of globulin production, which has implications for coagulation, inflammatory markers like CRP, lipids and lipoproteins are altered. You get a greater HDL with oral than you do with systemic or transdermal. All of these affected by dose, potency, and the bioavailability of the products that you use. In general, estrogens decrease inflammatory markers, so that's all good, with the exception of CRP and MMP, the matrix melanoproteinases are increased with oral and not with transdermal. So this is CRP, oral in the white, so the transdermal is a reddish, no change in CRP. So, and there's no evidence that that inflammatory marker does any damage when you give it orally. It's just an effect of the first passage effect. And these are the MMPs. If you look at MMP9, which is a major coagulation factor potentially by breaking down the plaque of coronary vessels, this was the theory of early harm. If you give a large bolus of oral estrogen to women with established osteoporosis, you increase MMP9, breaks down the plaque ruptures, you have a heart attack, okay? You get that with MMP9 in the last panel there with oral, but you don't get it with transdermal, okay? So very marked effect. And then, what about fat analysis? So this is a little bit of a tangent, but I think general health, quality of life issues. Oral is on the top, transdermal is on the bottom. Oral estrogen tends to increase leptin, whereas transdermal tends to increase adiponectin. Adiponectin is good, leptin is bad. And if you look at the LA ratio, leptin to adiponectin is much more favorable with transdermal. So for body fat accumulation, transdermal seems to be better from a metabolic standpoint. Similarly, for insulin resistance. Now, a caveat about these studies which we conducted with, these are more obese postmenopausal women. They're women who sort of had a metabolic syndrome, so it may not pertain to a thin, non-metabolically challenged 50-year-old, okay? But in the worst case scenario, what we see with oral in a compromised individual is worsening insulin resistance. So you have a reduction in Quickie and an increase in HOMA, which you do not see with transdermal. Progestins, okay? So it's incredible that this has gone round and round and round ever since the 80s, right? So we had an international consensus meeting. You can see how young we all looked in those days. Malcolm Whitehead and I put this together because we were really concerned about the impact of progestins and the attenuating effect on what we thought in those days and now believe again that there's a coronary benefit, right? So if the progestins attenuate the benefit even by a little bit, it would result in loss of lives, right? So that was the basis for this. And indeed, if you look at the 13-year data from WHI, I don't expect you to see the details, but the yellow, the sort of the arrows point to the differences between CEE MPA and CEE alone. It's definitely worse when you add the progestin, right? So you get true coronary benefit with estrogen alone, but you don't. It's neutral with CEE MPA. And so why is that? We think there may be some attenuation, and yet, you know, they're different populations, or if you're a purist from an epidemiologic standpoint, you say they're not randomized trials, you can't really say that. Yet we have data from DOPS, right, from Schrebeck, showing this benefit, a reduction in coronary endpoints sustained over 16 years, was with a preparation containing norethindrone acetate. So not all, and Tommy McCullough's data, you know, are same using estradiol and norethindrone acetate. So there are other data there showing that certain progestins, certain administrations can still achieve the goal point, the goal of coronary protection. So in terms of pharmacology, I'm going to just give you an overview here. There are many types of progestins, the synthetic ones. The androgenic ones obviously are worse in terms of metabolic parameters, but are much more potent in protecting the endometrium, which is a primary reason. And then you have the anti-androgenic ones and the ones that are relatively neutral. The characteristics of oral progestin administration is its bioavailability. Okay? Micronized progesterone, which we like to use, is very non-bioavailable. Very little gets into the circulation, even if you micronize it, compared to levonorgestrel, which is the most potent and most androgenic, has almost a 90-odd% bioavailability. So, you know, you get a very potent effect. So endometrial hyperplasia is what we're trying to avoid, right? This is the only reason for giving a progestogen. And what you really want to do is you want to shut off with the progestin the biochemistry of the endometrium. Shut off the receptors, increase the sulfatases and dehydrogenase activity to inert the estrogen being there. But it's time dependent and it needs about 12 days to achieve this end. As you can see here, these are classic data from Roger King and Malcolm Whitehead. If you look at NET here, very little is required to do that because it's so potent, right? So 1 milligram, 2.5 milligrams, all gets the estrogen receptors below that threshold. But if you go to the far right, look at progesterone. This is a sequential regimen. You need 200 to 300 to get that same effect as 1 milligram of norethindrone. But it's really about the biochemistry. If you want to prevent hyperplasia and ultimately endometrial cancer, you turn off the apparatus. Whereas the histology and morphology may lag behind it. You don't necessarily need a full secretory endometrium, which is why we don't go too heavily with the progestin doses, because it doesn't matter what the endometrium looks like. If you turn off the biochemistry, you're less likely to attenuate the things you want to prevent by giving estrogen. And of course, the more progestin you give, the more withdrawal bleeding you have. So what about direct delivery? Okay, so it's very popular to use levonorgestrel in the uterus. The concern there is that the Mirena product is too big. Not only physically, but it releases too much levonorgestrel. The product on the left has never been marketed. The levels are about half. So with a typical Mirena, you get about 200 picograms of levonorgestrel, okay, like the mini pill. It's too much. It reduces HDL, particularly if you're not giving a lot. So for long-term therapy, it's not a great idea. We need a different model, a lower dose, perhaps a different progestin. You can achieve that somewhat by just giving it vaginally, right? If you give vaginal progesterone, you get a higher intrauterine concentration, first passage effect, and that's why we use it in ART models as well. And so you can get, you know, near atrophic endometria if you prevent that hyperplasia. But if you give it in a continuous combined regimen, like a typical oral continuous combined, one of the concerns is breakthrough bleeding. And it's because you get this sort of venous ectasia of that combination of chronic progestin effect on the endometrium, and there are various ways to deal with that. So the question is this attenuation, back to the original premise. So the data are mixed. Randomized trials like WHI show some attenuation, but they weren't randomized trials. The Danish and Finnish studies do not. No major effect on blood pressure. There is probably some increased VTE risk with added progestin, with some progestins in some studies. And mixed data, but a little bit more with ischemic stroke as well. Old data from Tom Clarkson were quite convincing that you do get this attenuation. You get a coronary benefit with estrogen, and you attenuate it with, in this case, MPA, which is really not the best progestin to use. What about the breast? The concern with breast cancer risk is probably the added synthetic progestin. You can decrease the proliferation of breast tissue by an anti-progestin, and this is using mifepristone, or RU46. And this is breast density as a surrogate for this epithelial proliferation. You get a little bit with estrogen that's sometimes not statistically significant, but much more with estrogen and much more with continuous combined, increase in breast density. Now, whether this increased breast density as seen on mammogram translates into breast cancer risk is not known, but it just makes you think that it is having this effect on the breast. So finally, what about non-progestin therapy? So we have in the United States and probably other places in the world, BZA paired with conjugate equine estrogen, and this is a gene clustering. I don't have time to go through the details, but it shows a different gene profile if you pair them together, right, as opposed to each separately. So it gives you a different product at the tissue level, and this is so-called the TSEC model of non-progestin therapy. So this is pairing CEE with BZA, and you can see 4 studies now, randomized trials, reduction in hot flushes, improvement in vaginal health, reduction in bone resorption, right, all the things you'd like it to do, and a very high rate of amenorrhea. You're not giving progestin, you're giving BZA, which does not attenuate estrogen as much on hot flushes, on bone, and so forth, and yet will keep the endometrial tissue in check without that funny-looking endometrium you get with continuous combined. So you have a very high rate of amenorrhea, and Dave Archer may elaborate on it a little bit more. So what about the future then? Personalized medicine, of course, and pharmacogenomics, and profiles. I'll give you a little tidbit as an example, right? If polymorphisms of the estrogen receptor may have a role in all-cause mortality as well as cancer-related mortality. So in the future, perhaps, with genomic medicine, we can curtail a therapy to a woman's genotype, both dose and type, for long-term health. Thank you.